So a few quick facts about the reflex pathway. Then we'll move on to the defects one by one. So first is the center. You must know the center. The center is the pretectal nucleus. I've already marked it here. The pretectal nucleus, and the pretectal nucleus, it is located in the rostral midbrain, and it is at the level of the superior colliculus. Yes, so there you have the pretectal nucleus. And what is the afferent limb of the pupillary reflex? It is the optic nerve. What is the efferent limb of the pupillary reflex? It is the oculomotor nerve. Uh, so just a query here. What about near reflex? Actually, the center for the near reflex is not yet characterized. Uh, it is said that it is much the neurons are passing much more ventral to the pretectal nucleus. That is why when there is a penialoma, the dorsally located internuntial neurons from the pretectal nucleus are involved, but the light reflex is the near reflex is spared. The dorsally located internuntial neurons of the pretectal nucleus, that is, for the light reflex is involved, but the near reflex is spared, and it has some supranuclear influences also, the near reflex. Now let us move on to the afferent pathway defects. Afferent pathway is this one. So the afferent pathway defects. So the afferent pathway defects, the first one is AAPD or TAPD. Afferent pathway defect, that is absolute or total afferent pathway defect. So what can you say? That is an absolute lesion, that is the complete there's complete cutting of the optic nerve. So the optic nerve lesion, complete optic nerve lesion on one side. So what will happen is, when the patient presents to you, of course he's having one normal eye and one involved eye. So one normal eye and one involved eye. When he comes to you, is coming from outside, so both his eyes will be constricted, equally constricted. So suppose if the defect is in the right eye. Now when you start to test, when you throw the light on the normal eye, so left eye is the normal eye. If you throw the light on the normal eye, there will be both direct light reflex and consensual light reflex. So normal eye, completely normal, you will get the consensual light reflex also. But when you throw the light on the defective eye, when you throw the light on the defective eye, what happens? The optic nerve is completely cut, so the ipsilateral direct light reflex is absent, and also the contralateral consensual light reflex is also absent, because no impulse is going from behind, going from here, because the optic nerve is completely lesioned. And also what will be there? There will be ipsilateral anopia. Yes, the left eye, if the right eye is involved, the right eye is completely anopic or completely blind. But what is preserved? The near reflex is preserved. So for near reflex, the vision is not a prerequisite. For near reflex to occur, vision is not a prerequisite. So in both these cases, when we are testing the light reflex of the right eye, in both the cases you will get isochoria. Okay, in both the cases you will get isochoria. Why? Because when you test the light reflex of the right and the left, in both cases you will get isochoria. When you are testing the left eye, yes, both will right eye that is damaged, both will be dilated, because nothing is happening. When you are testing the left eye, both will be constricted, because both are normal. So both pupils will be in the same shape, that is isochoria is happening. Okay.
So the second afferent pathway defect is RAPD. What is RAPD? Relative afferent pupillary defect, or it is also called Marcus gun pupil. Marcus gun pupil. So, where can it be seen? Yes, it is seen in the partial optic nerve lesions, right? Partial optic nerves. Earlier we saw the AAPD or absolute pupillary defect, absolute afferent pathway defect in complete optic nerve lesion, but here it is partial optic nerve lesion and also severe retinal diseases like retinal detachment, right? Like retinal detachment. So in partial optic nerve lesions, or like when the optic nerve gets is starting to get involved, like optic neuritis in case of beginning of optic neuritis, and in certain cases of CRVO, that is retinal venous occlusion, then retinal detachment, also severe retinal disease also. Now what is this RAPD? Now you got it. Now how can you know that the patient is having RAPD? So for that, to elicit this relative afferent pupillary defect, that is with relation to the normal, the abnormal eye is having a defect. So to elicit that, we are going to use the swinging flash light test. Swinging flashlight test. So what do we do? The light stimulus is alternatively shown on both eye, that is swung between both the eye, right? So that is what you call the swinging flashlight test. So okay, what is the mechanism behind it? The defective eye, the optic nerve of the defective eye get fatigued easier. That is what happens. So earlier fatigue of the partially lesioned optic nerve, that is what happens. So this is the background illumination that you give. Now this is in that background illumination, both eye illumination, both eye are dilated. Here left eye is involved. Now first we are showing the light into the normal eye, the suspected defect is in the left eye, so we are throwing it to the normal eye. Okay, the direct and the indirect or the consensual light reflex, okay, we got both are constricting. Now you may not get this finding in the first swing, you may have to repeat it further, but for demonstration purposes it is shown like this. So we swing the flashlight to the next eye. So when you are swinging, so for a brief moment here, the light is not here also, the light is not here also. So when you just take it away, this starts to dilate, right? You may not get it in the first, you may have to swing it some more time. So here, so there is only, when your torch is here, only background illumination is there, so the pupils start to dilate. Then when you swing back here, if the optic nerve is fatigued, you will not get as strong as a stimuli as from here. Relatively weaker stimuli. The pupil respond weakly to stimulation of diseased eye and briskly to that of normal eye. So here it is a weak response, here brisk response. Because of that weak response, when we show the light to the diseased eye also, it will continue to dilate. So it is paradoxical, isn't it? It's a paradox. We are expecting to constrict, but it is dilating. So it is of course a paradox. So there is a paradoxical dilation, or the pupil escapes So it is a pupillary escape phenomenon or a paradoxical dilatation is seen. This is called the this is what you get in case of a relative afferent pupillary defect when you do a swinging flashlight test. So let us just look at one more image. So this is a real life image, and let's see. You have to identify which is the abnormal eye. So we are throwing light into one eye, then you are swinging the light into the other eye, same mechanism. So of course this is the right eye of the patient, this is the left eye of the patient. And when you are swinging here, see, after the fatigue, it will not be present in the first swing sometimes. So after the fatigue happens, see, it is still dilating. When you throw come back to the normal eye, it is constricting, brisk response. When you go back to the abnormal eye, it is dilating again. So here, left eye, alright, swinging flashlight test. Through swinging flashlight test, we are coming to the conclusion that the patient is having RAPD. Okay, so one more point is that you in the so there are some media through which light passes, right? Through the cornea, through the anterior chamber, through the lens. So if you are having a dense cataract in the lens, what do you think? Will you get an RAPD? No, the RAPD is due to the optic nerve getting fatigued easier, right? So a dense cataract or maybe an amblyopia. In all these cases, you won't get a what RAPD. And also in case of maculopathies, you won't get RAPD.